So without further ado, I'm going to introduce to you our first speaker, Hiyam Nadel, RN, MBA, BSN, CGC from Boston, Massachusetts, Massachusetts General Hospital. Hiyam.
Thank you, Rebecca. I just want to say I'm really thrilled to be here today to present our work at Mass General Hospital in Boston. When you think about innovation and inventions, it is a well-known fact most of those come from people either deeply experiencing the problem or are the closest to that problem. And let's think about nurses who are with patients all the time and develop a deep understanding of not only patient, but family needs and hospital system needs as well. And yet, there are no formal structures in place for those frontline caregivers to help with innovation and advance healthcare outcomes. And that's what we are trying to do at Mass General Hospital. So where do we begin? We began by developing what we call the Idea Awards. And what that did simply was email all staff that reported to our chief nurse. That included nurses for the majority, as well as the therapies, social work, and chaplaincy. And we said, look, just give us your ideas. What innovative ideas do you have? We put no parameters around those because we really wanted some insight as to what those problems were at the front line, and also to develop or assess what is the baseline knowledge when we say innovation. We received 40 applications out of 8,000. And so we have 8 of those projects incubating at all different levels, but just some that I would like to review. The PEG-PAL is for ALS patients. And as ALS patients decline in the ability to feed themselves, these staff developed cuffs, digit cuffs, to advance or continue to help them feed themselves as they decline. So the adaptive feeding kit was a really big hit. Also, you see in the second slide, we have our nurses who are on the pediatric biothreat team. And it occurred to them they were completely protected with their PAPRs and their protective gear. And yet, when they drew bloods from a pediatric patient, they had to transfer that blood into a micro container or another syringe, leaving them at risk for needle sticks and blood splatter. And so they developed a shield to help prevent that. And this scaled to even our lab personnel who inject things in tubes and decided that this would protect them as well. And then in our neonatal intensive care unit, we know some babies go on and develop the language delays. And so this staff person developed the parents' voices that can be placed on the baby or placed in the incubator, where that baby could hear the voices of their parents in the right decibel, the right frequency, the right attenuation, and at the right gestational age. And so when we talk about these projects, we talk about really the beginning of the upskilling of our frontline staff to solve problems through human-centered design and design thinking. And this is a different way of approaching a problem. During the pandemic, we were all at the front lines, but it gave us an opportunity in particular to really reflect on what we've been doing. And why is it that we only have 40 applications? Is there some way that we can reach deeper into the front lines? And so we pivoted to what the Etherdome Challenge, which is an open innovation contest that was designed in collaboration with the Healthcare Transformation Lab and the Harvard Business School. And it was an opportunity to really engage all staff at all levels, democratizing the innovation and creative problem-solving ideas over titles. There were 4 rounds, The submitting challenge round was where they can just submit their pain point and their idea of solution and their ideas for a solution, just very quickly on a phone, on a computer, really reducing any barriers to submitting ideas. And then round two, the crowd voting. Those same staff were able to go in and vote for the ideas they wanted to rise to the top. In round three, we took the 4 top voted ideas and then asked them to submit a full application. And then, of course, we picked the 4 winners. So we did this at the second surge, and we were really concerned whether the staff were engaged. They were exhausted. The capacity hadn't changed. The acuity level and how sick patients were continued to rise. But I'm happy to report that we received 225 ideas. And we put them in different buckets because this was what was important to that staff. So capacity management, growing complexity of the clinical environment, patient and care team communication. And they started to believe that transformative ideas can come from anyone. Again, questioning whether we were going to engage in the crowd voting, we received almost 16,000 votes from our frontline staff. And we were so thrilled about this because we really did engage our staff. And what this tells you is an emergence of priority problems from the community themselves. We weren't involved at all, other than communicating that it's time to vote, time to submit your application. This all came from the front lines. And so these are our 4 winners. And we will begin to work with them and mentor them in incubating their ideas beginning in March, hopefully if the staffing improves from COVID. And we're infusing the innovation mindset. So when I'm on the units, rather than hear, oh dear, we have problems, that we're pivoting to, yay, we have a problem, because this gives us an opportunity to innovate. And because the Etherdome had lots and lots of data analytics power, we were able to see what role types actually submitted, what tenure there were that submitted ideas, did it come from ambulatory versus inpatient, et cetera. So we can now try to inspire those staff that didn't have the opportunity to experience. So we learned a lot from that. We learned a lot that we have to engage our community and ambulatory staff again next time compared to the inpatient. We lowered the barrier, so we didn't start out with an application. We just said, submit your idea and let's hear about it. And we closed the gap with leaders, meaning that we involved our leaders in decision-making right from the get-go. They were able to hear directly from the front line so they could assess what they perceived as gaps versus what the front line was telling them was the problem. And of course, this was a very therapeutic, infusing joy, empowering process to the front lines during this dark times. And so what's next? We'll have multiple publications will be coming out around this challenge because we studied it a lot from the behavioral economics perspective. Our next challenge will be with patients because we want to co-create with patients. We will start our staff mentorship. And we're finding ourselves that we're scaling to a larger ecosystem. For example, we've been meeting with the NIH to try to inform and impact some of the funding towards nurse innovation. We're meeting with the National Innovation Summit that's trying to impact education, practice, and policy. We've been talking to the United States Public Health Service that would like to do a challenge such as this to really engage all of those nurses in the public health service. And just yesterday, we talked to people in Israel and Africa who actually want to advance their innovation work, and we're going to help them do that from our lessons learned. And of course, we've been getting interest from industry. We're finally shifting that paradigm, and that they're seeking us to co-develop or test their equipment and processes prior to commercialization. And so what I've learned is that we have the power of we. If we all engage together and really co-develop and co-create, there's nothing like it. And I do want to just take 30 seconds to say some thank yous, especially to my MGH leadership, because I have the best bosses on the planet. And to the Canal family, through their generosity, none of this would be possible. To CCL for letting me get to know myself and build upon my strengths. To Nurse Approved and Sanciel for your mentorship in developing our ideas further. And Johnson & Johnson for giving me instant credibility. They all said, Hiyam must know what she's doing. She's a Johnson & Johnson Innovation Fellow. And to Linda Benton, on a personal level, you always talk about throwing a pebble and looking at the ripple effect. I want to assure you, you have impacted multitudes and multitudes of frontline caregivers and the downstream benefit to our patients. And that's why we're all here for. Thank you.
Hiyam, that was a beautiful presentation. And one question that we have, other health systems, learning that you were the first nurse appointed as the director of Center for Innovations at Massachusetts General Hospital. I mean, that just by itself is groundbreaking. The question is, how could others take this to their system that have not necessarily been seeing nurses as innovators, and why should they and how can they bring that forward? What advice would you have for them?
I think what we did was I met with my chief nurse and we explained all this to them. And we said, let's just start somewhere. So it didn't take a lot of funds. It didn't take, but just to get the ideas coming from the front line. And I have to believe that our leadership is always interested in that pain point that's coming. And just let's see what they are. And let's try to work on them. And I did have to, I was a nursing director for ambulatory at the time, but you have to just sometimes go above and beyond and work on these ideas just to build your credibility.
And another question that followed up on that, what has been the biggest challenge as you've sought to implement this approach?
I think the biggest challenge is it's easy to get people to contribute their ideas, for example. But how do you build it? What are the resources that you need? And I think those are things you have to think through. And we were lucky because we did receive philanthropy money. So funding is really important to help, build out these ideas because we needed prototypes. But first, it was interesting because we looked within our own walls to see how we can collaborate with other centers. So for biomed engineering, for example, and they had a 3D prototyping suite that we didn't even know. So really looking internally and see how much you can build out without having to get all this funding and money.
I think we have time for one more question, so we're going to expand on two of them, which is, how did you actually start to form these partnerships, one with the public health service, but also industry, for them to hear you, see you, and what is happening in that space? Because I think a lot of people assume that, those would be handled by people outside of just, a center of innovation, because there's so much complexity there. How did you undertake that? And how did you establish those to be effective and run through your center as opposed to traditional partnerships through organizations such as your own?
Yes, and I think the hackathon and building our network really just started there, and people reached out and said, can we just get on a phone call, tell us a little bit more about what you're doing, and then they're telling us what their needs were and what their ideas would be, and just saying we would love to help you because right now that's what we need to do. And I think Susan Hassmiller made a beautiful point, is the networking and developing your own tribe to really advance the work of innovation.
One great question came in that I have to ask because it is the question of the hour for so many nurses. How did you handle the institutional versus the individual intellectual property, as this is an issue so many nurses are facing? And then we're going to talk about a little bit down the line at the end of this, how you actually took this as an advantage to research and magnet status. But tell us first how you dealt with that complicated issue that I know is a breaking point for so many nurses today.
So again, looking internally within your institution, because most of them have something set up to help staff that do invent with applying for provisional patents and beyond. So really meeting those people and understanding what the rights are. But that's really what we're doing. When you're inventing within an institution, most of the time they do own your intellectual property. However, if you've done something outside of the work, completely independent, on your own time, they do not. But I find that it's quite an expense to file for these patents. So don't be afraid to let your institution, because you still will benefit by it. And then in terms of, a lot of our projects eventually will need to be researched and presented, and there's a big overlap with our research. So I reach out to our nursing scientists. We're trying to collaborate now, so all these projects can be tested in a more powerful way and with publication as well.
Well, Hiyam, thank you for your time, your incredible leadership, your vision, and really building out the first nurse-led innovation center within a health system at a place and time that was probably one of the most transformational, not only for healthcare in general, but for nursing. And what an exemplary example you are to the world. And it has been such a pleasure and excitement working with you the last 2 years, because I think if there's one thing that has really given us hope is watching how you have been able to help implement into a system and get their support to see nurses differently and have a seat at a table unlike we have ever seen for our profession before. So thank you. We will follow up with some more group questions at the end. And thank you for your time.
Thank you, Rebecca. And I do want to say, when we involve the leadership, they are so excited to move most of those ideas forward. So I think it's a big strategy that you need to think about.
Absolutely. Strategy is absolutely the name of the game here. So thank you, Hiyam.